Good afternoon. I'm here to present on the Real DX case 285. This was a 16-year-old female who presented with shortness of breath, wheezing, and cough at our primary care clinic. So this 16-year-old female presented with increased work of breathing, cough, as well as some associated audible expiratory wheezes that started about a day ago, shortly after playing basketball with her sister and father. Her associated symptoms included her lungs starting to hurt and her feeling like she could not breathe well. She's never been diagnosed with asthma and has never been hospitalized for asthma or for anything in the past. Her review of systems include in general, constitutional. She denies fatigue. She hasn't had any significant weight loss. My review of systems will be a little bit focused since this was a focus visit. She denies having chest pain or palpitations. Her respiratory review of systems is positive for the shortness of breath, wheezing, and the cough. And then just quickly, GI, she denies nausea, vomiting, or abdominal pain. Her past medical history, as I briefly mentioned, she has no known medical history. She does not smoke cigarettes, and from the information that's available in Real DX, she does not drink alcohol or use any other substances. She also does not live with any smokers at home. As well as for medications, she does not take any current medications either. On her physical exam, it's significant for the presence of audible inspiratory and expiratory wheezing. She does appear to have an increased work of breathing. Her vital signs, for the most part, are normal. Her temperature, afebrile at 98.7. Her heart rate is 91. She has tachypnic at 28. Her pulse ox is normal at 98% on room air. And then her blood pressure is 124/83. We were able, in our clinic, we were able to get a chest x-ray on her. The PA lateral film was clear. Her airway appeared midline. She had appropriate borders and landmarks. The film appears to have, like there's 9 ribs present, so signaling that it was taken on inspiration. There's no cardiomegaly present and no infiltrates, which is what we were looking for in her case to rule out pneumonia. Her peak flows were as follows, the first one being 200, the second one being 210, and then she received 2 albuterol treatments and her symptoms slightly improved, and then after her third treatment, her PF improved, her peak flow improved to 300. And at this point, she is speaking full sentences and appears to have improved work of breathing during our evaluation. So with that being said, her most likely diagnosis is acute asthma exacerbation with a bronchospasm. So her asthma, with this being kind of an acute visit, does essentially fall between mild and moderate asthma. And so the first thing on her problem list is the asthma exacerbation with acute bronchospasm. And for that, we did have a few diagnostic studies done already. But one thing that we'd like to do is administer the asthma control test to really help categorize her asthma more specifically. In terms of her initial treatment, we will continue albuterol. And in the outpatient setting, instead of the nebulizers, we actually could, if we have available, do 4 puffs of albuterol with a spacer every 20 minutes for the first hour, and then starting her on prednisolone. So she would take 1 dose of 50 milligrams now and then continue it for 5 days. Tapering would not be needed per GINA guidelines, considering we're prescribing this for less than 2 weeks. For her long-term treatment, we definitely like to establish her baseline spirometry when she's feeling better. Given her initial presentation with an acute exacerbation, we'd actually want to follow step 3 GINA guidelines, and this follows a little bit more aligned for moderate asthma. But again, we'd be able to categorize that a little bit better after administering the asthma control test. But regardless, we'd start her on a daily budesonide formoterol inhaler, 160 over 4.5 micrograms. So this would be a low dose inhaled corticosteroid with the long-acting bronchodilator. And then we'd also want her to have a PRN available, as for all asthmatics. So that for her would be a SABA, a short-acting bronchodilator, which would be albuterol. Before she leaves this visit, we'd want to ensure correct inhaler technique, and we'd continue to reevaluate that on future visits. We'd also want to establish an asthma action plan. So this includes discussing triggers and creating the plan before she leaves to go home. In the green category, we would have her identify when the breathing is good, her being able to sleep through the night, not having any cough or wheezing, and continuing her ICS LABA daily. If she were to be in the yellow zone, that's when she's exposed to triggers. For her, it would likely be the exercise, any mild wheeze or mild chest tightness. At this point, she could use her SABA, her albuterol reliever. And then in the red zone, she is at a point where medications aren't helping, breathing hard and fast. That's when she needs to contact us ASAP to discuss with her provider. For referrals, we could consider a pulmonary rehab referral. However, she likely doesn't qualify due to her age. And then we definitely want to consider a dietitian consult depending on her BMI and her weight. For her follow-up, we definitely want her to return to the clinic within the next few days. I would say 3 to 5 days. And then for her to call or schedule a sooner appointment if symptoms worsen. In terms of her health maintenance, that being the second thing that we want to address in our assessment and plan, for her immunizations, given she's at an age of 16, we want to ensure all of her childhood immunizations are up to date and educate regarding the influenza vaccine for this fall, especially given that she's a newly diagnosed asthmatic. We definitely want to perform any STD screening if she is sexually active, and then we want to talk to her about physical activity, again checking her weight, BMI, and then recommending 150 minutes of physical activity per week, and then talking to her about how to incorporate asthma control and incorporate that to her asthma action plan. With that being said, this sounds like a comprehensive plan to me, and I look forward to your feedback. Thank you so much.